Good morning. I just wanted to make a very short video on cough impulse. Now I am making single findings, how to elicit, what are the false positives, when it can be the particular diagnosis, but cough impulse can be absent and so on and so forth. I'm just feeding single diagnosis into the presentations so that you are not unnecessarily overwhelmed with too many clinical findings at the start itself. So coming to cough impulse, let's keep it as cough impulse. I will tell you why exactly it cannot be just a cough impulse. It needs one more objective there. So as I told you, these are from my personal collection and they should not be a substitute for your direct patient interaction. Now, what are the differential diagnoses of a purely inguinal swelling? You see, this is a pure inguinal swelling. It has not gone into the scrotum. Now, as the teaching goes and as the learning goes, there's a lot of confusion. If you divide those swellings as pure inguinal, pure scrotal, and inguinoscrotal, your understanding will be much more clear. So then just don't think about all the DDs happening in all this area. Unnecessary taxing your head. Swellings only confined to inguinal area, what are the DDs? Swellings confined only to the scrotum, what are the DDs? Swelling confined to both inguinal and scrotal area in the same patient, if there is an inguinoscrotal swelling, what are the DDs? If you have put this sort of demarcation, it's much easier for you to understand. So today we are not going to talk about scrotal swellings. We are not going to talk about inguinoscrotal swellings. We are going to talk about plain inguinal swellings. Finally, I will wrap up all the three. So the diagnosis of a purely inguinal swelling will be an inguinal hernia. Now this can be reducible or irreducible. The next common will be lymph nodes. And any tumor of soft tissues in the inguinal area, starting off from the skin, the subcutaneous tissue, there is a muscle there, there are nerves there, there is also an underlying pubic bone there. So it can be any swelling from the skin and soft tissues and the bone of that particular area. A psoas abscess. A psoas abscess will track along the psoas and present here. And an aneurysm of the external iliac artery, you can get an aneurysm here. It will be confined only to the iliac region. I have a video, I'll put it up later. Now today we are going to talk only about cough impulse. Now a cough impulse will be positive in a hernia only when it is reducible, and irreducible hernia cannot have a cough impulse. So the reduction can be either spontaneously it reduces on lying down, or you need to reduce it and then look for the cough impulse. If the hernia is irreducible even on manual reduction, then you obviously cannot look for a cough impulse. Now, once you get a cough impulse, then you can decide in the inguinal area, you can decide whether this is direct or indirect. First, you confirm cough impulse, yes, it's a hernia. Next, you can decide whether it's direct, indirect, complete, incomplete, about the contents and various other parts of the hernia. Now, what exactly is the cough impulse? Coughing, laughing, sneezing, and defecation will produce a raised intracranial intra-abdominal tension. It will raise the intra-abdominal tension. Now, this abdominal tension will get transmitted through the peritoneum, which is anyway patent and lying in your scrotum, which is your hernia. Obviously, in your clinical posting, you can't ask your patient to laugh, sneeze, and defecate to raise the intra-abdominal tension. So what do? You ask him to cough. Now, this is transmitted into the peritoneal sac and the contents. So what happens? The contents, now because it's got transmitted into the sac, it will expand and more of abdominal contents will come in. So you can see that movement also. That is known as expansile cough impulse. It is not just an impulse, it has to be expansile also. Reduction means reduction of contents, not the sac. Now, one more point I wanted to stress here, because I can't make a separate reel on this. When you say reduction of a hernia, you mean the contents of the hernia that you're able to reduce, or it spontaneously reduces. You don't mean the sac. You can't replace the sac back into the peritoneal cavity in your clinical examination. In your intraoperative, probably you can place the sac into the peritoneal cavity. So keep these two things in mind. And coming to the real cough impulse, let's have a look. So it is called an expansile cough impulse. A cough impulse that is expansile is the pathognomic sign of a hernia, provided it is reducible either spontaneously. On lying down it disappears, or he is able to reduce, or you are able to reduce. But there are subtler ways and less disturbing way of eliciting that reflex. That is by asking the patient to do Valsalva. When you forcefully breathe against a closed glottis, obviously you will raise the intracranial pressure, the intra-abdominal pressure and the intrathoracic pressure. But that activity is quite comfortable to a patient, one. Number two, you will not have jerky abdominal wall movements that happens during cough. So that you will, unlikely that you will miss the expansile cough impulse in the midst of these abdominal wall movements which happens during cough. Whereas Valsalva will be very silent, just the cough impulse will be happening. That is why you ask them to do a Valsalva. Number two, patients are more comfortable doing the Valsalva. And number three, he easily understands it. Everybody is doing a Valsalva at some point of their lives. Either they are trying to stop themselves from sneezing, they are straining at defecation. So they know that activity. It is not tough on them. So let's have a look at the video. You're asking him to cough. See, now I'm asking him to do only Valsalva. Okay, now let me replay the video again. Now, this is a recurrent hernia. You can see the scar. But my objective was to show the expansile cough impulse. So in the inguinal area, you will have an expansile cough impulse. Now, just watch the first two frames. He is coughing. You can see the whole abdominal wall moving with the cough. But in the third frame, I am asking him to do Valsalva. The rest of the abdomen will be silent and you will only find the expansile cough impulse. Now, I cannot explain this when the video is on. You will get lost in the noise. That's why I'm giving the explanation and then putting up the video again. When he is doing Valsalva. Not only that, you're also able to see the bulge on the left side. So, as usual, I will request you to share, like and subscribe, and there's a Telegram channel also which is being parallelly running. And thank you again. We'll keep posting one by one clinical finding of a hernia, and finally I will compile it into a single video presentation. Thank you.